Thank you for this opportunity to present our paper. Actually, I was the second author. My colleagues Anmar and Ola were part of the team. It was a systematic review to review the ERCP complications, post-ERCP complications. So it was a review of the microbial patterns, incidence, risk factors, and management strategies in contemporary practice. Actually, I am one of the upper GI surgeons. I'm working in King's College Hospital in London. As we know, most of us know, ERCP is the endoscopic retrograde cholangiopancreatography. It is a minimal invasive procedure, and we achieve two goals from ERCP, either diagnostic or therapeutic. It is a minimal invasive procedure. It is an endoscopy, but there's like some complications. So we may consider it a high risk procedure, and most of studies speak about 10 to 15 complications, 10 to 15 morbidities, and 0.1 to 1.5 mortality rates. So although it is a minimal invasive procedure, there will be always risk for complications. When I speak about ERCP got many challenges due to the anatomical map of the common bile duct and the pancreatic duct, and the way they insert themselves into the second part of the duodenum. So there will be always some technical challenges, and this one of the major causes why we face complications with this procedure. There are many complications. The most common is the pancreatitis, the acute pancreatitis, and the other major complications is infections in the form of cholangitis and bacteremia. Other complications include bleeding, perforation, and some general complications that may happen with any procedure, which are mainly the cardiopulmonary events. Most of these complications result from the major papilla swelling. Major papilla is the site of the insertion of these ducts into the second part of the duodenum. Sometimes iatrogenic causes due to either mechanical or thermal injuries, or maybe related to the contrast agent that we inject during the procedure. Why this area? Why this region is amenable or is high risk for infection? Because it is it has the complex anatomy, many angulations, and number two is during the procedure we may introduce some microorganisms. The third main cause is the limited blood supply to the biliary system. So the last thing is sometimes with ERCP we cannot achieve completed drainage. That means further stasis and like perfect environment for bacterial growth. Another challenging issue with pancreatitis is the increasing prevalence of multi-drug resistance, especially the vancomycin resistant enterococci and the extended spectrum beta-lactamase producing bacteria and carbaminin resistant organisms. So this one of the major challenges that we are facing in our practice with the ERCP. Other issues like changing patient demographics. For example, more patients with malignant biliary obstruction. So malignant biliary obstruction is another challenge. Patients with previous surgeries and with complex medical conditions, and in the recent couple of years, ERCP in the private sector with discharging the patient straight away after the procedure is another issue. In our practice, usually after ERCP, we keep the patient for 24 hours after observation. Other side of our paper was to do some risk assessment and prevention to decrease the morbidity and improve the practice. So there are some risk factors with ERCP that may increase the odds of complications to happen, such as age, gender, sphincter of body dysfunction, previous pancreatitis, and underlying disease. These are patient factors, and we have some procedure factors which may be related to the operator experience and if there's any difficulty in cannulation, pancreatic duct injection, and if there is any specific interventions. So we will speak about the prevention as well. How can we prevent, how can we predict the risks, and how can we prevent them? So basically, it is a systematic review. We follow the PRISMA guideline, and our research question was formulated using the PICO, the Population Intervention Comparison and Outcome. Our main question was, what are the microbial patterns? What are the incidence rates, risk factors, and management strategies for post-ERCP complications? And how do these findings inform contemporary clinical practice and future research directions? So the main goal is to improve our practice regarding ERCP. Our inclusion criteria were patients above 18, patients from January 2004 and December 2025, and all the literatures in English language. Our analysis, so we searched 847 potentially relevant articles. With the application of inclusion and exclusion criteria, we ended with 10 studies. And these are the 10 studies that were included in our analysis. According to our study, the overall complication rates from ERCP were 9.4% to 15.9%, with a mortality rate of 1%. The main complication, the most common complication of post-ERCP was pancreatitis, and the incidence was around 3.8% to 17.2%. The second most common complication is the infection-related complications. So cholangitis in 2.4 to 9.7 in one of our studies, and bacteremia in 2.24. The other complications, such as the cardiopulmonary complications, were 2.3%. Perforation and hemorrhage were less. So this is a table to clarify the complication rates and incidence according to our analysis. According to our analysis, the main risk factors were patient age. So higher the age, older the patient, more high risk for complication. Number two, female gender. Female were more prone to complications, apparently poor female. And patients with previous history of ERCP procedure were more prone to have complications. And the last thing were patients with comorbidities. The other procedure-related complications were stent placement, hilar obstruction, difficult cannulation, high dose of antispasmodics, and if there's any over-manipulation of the pancreatic duct. Some protective factors were identified, such as endoscopic stone extraction, if our procedure include endoscopic stone extraction, that may help to decrease the risk of complications. If our operator is experienced, this is very good, will decrease the likelihood of complications, and the appropriate selection of patients is very important. Another main issue with ERCP is the microbial patterns. So recently, there are many pathogens identified after ERCP, which showed resistance to antibiotics. We are speaking about E. coli, Enterobacteriaceae, that may lead to life-threatening bacteremia. So 72.73 of E. coli isolates were resistant to ciprofloxacin, which we meant to use during or after the procedure. And the Enterococcus faecium isolates showed complete resistance to this organism. And only 37.5% of E. coli show response to ceftriaxone. And these are red flags that we are facing a rise in the resistance to antibiotics. So this is our microbial patterns that shown during the table. I will not go through the discussion because these are the comparisons with the other international studies. I will jump into the conclusion. So complications after ERCP is a significant clinical challenge, and 9.4 to 15.9 of complications is a high percentage with mortality of 0.26 to 1. So we need to raise the flags. The main complication was pancreatitis. Other complications were infections in the form of cholangitis and bacteremia, putting in mind the increased resistance to antimicrobial agents. So there are some risk factors such as age, previous ERCP history, if we're gonna place a stent, or if there is a hilar obstruction. So it is very important to have an experienced operator. And one of the beneficial things to do, if we have a stone, we're gonna extract it. This will decrease the risk of infection or complications like pancreatitis. So finally, we analyzed 10 studies, and we agreed that pancreatitis and infection are the main complications, and we have issue with resistance to the antibiotics. Our advice is to validate our study through a large-scale multi-center trials to try find clue for decreasing these complication rates and improve our practice regarding ERCP. Thank you. I'm happy to have receive any question or comments.